Okay, Assalamualaikum and good day for you all. So we teruskan dengan this part of lower extremities. So we can for ankle, foot and digits, or we call it as a toes. Okay, this is all your learning outcomes. You'll be reading by yourself. And so we go for the anatomy first. For the ankle joint, it is kind of a hinge type of joint that composed of three bones, which are the distal tibia, fibula, as well as talus. Okay, as you can see the hinge type of joint, kita dah pernah sebutkan pasal hinge type of joint ni selain daripada ankle, yang maksudnya yang boleh bergerak, yang connected and they can be flexion or extension tu So yang lain selain daripada ankle, we have a forearm as well, kan? Sorry, elbow, tapi flex as well. This is the image of the AP ankle actually. So you can see here, this is the part of talus, this is the part of tibia and fibula, right? And why for this one is ankle joint in lateral projection. So this is the calcaneum. You have to remember calcaneus, tarsal, the cobra itself, navicular, as well as cuneiform, talus. Talus yang join dengan talus is the one that form the ankle joint together with the part of the tibia and fibula. Anatomy of the foot pula composed of 36 bones altogether and divided into tarsals, metatarsals, as well as the phalanges. Okay, for tarsals is 7, metatarsals 5 bones, and phalanges is 14 bones altogether. So in total of the 26. Okay, betul ke? So this is the image showing the anatomy of the bones. The composition of the bones. Okay, kat mana metatarsals, phalanges ni, this is phalanges, okay, metatarsals, okay, as well as the tarsals here. The cuboid talus pun tu tarsals lah, okay, and tarsals here composed in 7 altogether, calcaneus, talus, cuboid, navicular. Calcaneus ni yang paling besar lah antara semua tarsals tu, navicular as well as first, second and third cuneiform. So 3, 4, 5, 6, 7 altogether. Sebab cuneiform ada 3 di sini And metatarsals consist of 5 bones. The bones are numbered from the first 5, each represent with the body distributed distal and proximal parts, and digits. This is the 5. Big toe je lain, hallux ni, with the phalanx bone, distal and proximal sahaja. Okay. Whereby for the other 4 toes, have 3 bones and 2 joints. Okay. And then phalanges are connected to the metatarsal by 5 metatarsals, phalanges joint, and at the ball of the foot itself. Before we go further, they have as well the first toe tu, big toe tu ada sesamot bone juga, bones tu dia tengok. And the parts of the foot itself have 3 main parts, which are the forefoot, the toes as well, yang function is for balance and bears half the body's weight and pressure on the ball of the foot. The midfoot, 5 tarsals bone tu yang ada cuboid, talus, forms the foot arch and serve as a shock absorber. And the hindfoot composed of 3 joints and link the midfoot to the ankle talus, forming a hinge that allows the foot to move up and down. Okay, so this is the hindfoot, midfoot and forefoot. Alright, this is just to highlight the joint itself and they connected all the midfoots. For positioning, we have the AP, lateral and oblique. Okay, most of the lateral is to see for the foreign body biasanya. Okay, for AP, for phalanges, digits and foot, we got AP and oblique for the basic. kita lateral kita just tunjuk jugalah sekaligus kita dah cakap pasal digits ni kan. Then ankle joint AP and lateral sahaja for basic projection. This actually additional projection ni akan lagi akan ulang dia ada lagi lah untuk special nanti kita belajar for IS2 specific to the for the additional view motif the lateral foot itself. Just but then dah ada kat sini, so kita mention juga dulu for you to have an exposure on the additional view. So AP anterior posterior of the digits of phalanx or toes sama this is all the indication to be mentioned, either OE, arthritis, fracture or dislocation. Okay, and gout pula is a disease in which defective metabolism of uric acid that causes arthritis, especially in the smaller bones of the feet. You tahulah gout kan, so dia ada penambahan terlebih uric acid dalam badan kita. Okay, so the technical factors involved, okay, yang saya kata beza cuma the exposure factor as well as the size of the image receptor that we use. Okay, example here for the digits, biasalah dia tak tebal sangat kan, yang paling nipis lah antara thinness antara yang lain punya tu bahagian badan. So it could be 45 to 50 and 2.3, 2.5 up to 2.5 for the exposure factors. Ini semua sama lah to be applied still 100 cm for the SID. Okay, so positioning dia, how is position? Either you are patient are seated or lie supine on the table. Alright, flex the knee with plantar, slightly flex, and it is the plantar surface will be resting in contact with the image receptor. Make sure you immobilize the foot if necessary, place the marker, apply the collimation, okay, tight collimation to just include the region of interest, okay. Di sini dia cakap pasal angulation. If cannot, setting point dia kat mana tu? Depends on what the digit itself lah. The phalanx either it is at the first toe, the big toe, ataupun ada phalanges ni. Alright. So tengok dia either with degree angulate the tube 15 degree towards the kaki ni, ataupun just apply the 15 degree of the sponge ni. Okay, so the more is a metatarsal phalangeal joint of the phalanx exam and directed vertical beam. This perpendicular to image receptor. If the 15 inches space under the foot, kalau pakai you letakkan immobilization is ni 15 degree tadi, sponge tu bawah foot kita, so just straight lah apply. But if you do not have any tak angulate the foot, then you have to angle the tube itself. This is to ensure that you are producing true AP position. The phalanges. Kalau kita tengok curve kita punya kaki ni kan lain. So it related with the anatomy to be projected. So it's supposed to be open space. This is the reason why we apply the angulation. About 15 degree. Okay, you have to ensure apa yang kena masuk ni all the phalanges lah, starting from the metatarsals until the end of all the soft tissue area ni to be included. Okay, so you apply the acetaminophen when you apply the long axis of the foot that align to the long axis of the portion of IR. Okay. This is actually all the phalanges lah. Okay. For the sama juga macam digits for the kaki ni, toes ni, apply sama macam kita buat dekat tangan ni apa tau. Phalanges at our finger ni, jari ni, finger sama je dengan toes. Okay, whereby when you are, contohnya kita nak project the the second two ni. Kan. So you at this you include part of the big toe as well as the mana? Kan. Enough to include this. Cukup lah. Okay. So tahulah actually sikit tak. Sorry. Okay. Part of it. Part of it. Part of it. Cukuplah 3. At least, so kita tahulah we are projecting the second. Kadang-kadang videographer juga suka tulis something lah after the after process tu, post processing tu ada marker tulis dia. And then go for oblique. Pathology is sama lebih kurang macam AP tadi. So positioning is you either tengok tools yang mana satu. Alright, if you are projecting the first, second and third digits, it could be medially lah, lagi dekat dengan image receptor. But for the digits of 4th to 5th, you projector the other way around. Kalau yang ni mungkin dia more to the toes, big toes tu. So they go for medial side of the to be close to the R. Apply the black shading as well as collimation to be tightly just enough to get the region of interest. Alright, the centering point is at the metatarsal phalangeal joint and direction vertical beam with the FTR perpendicular to the image receptor. Metatarsal phalangeal joint. Oblique toes here, this is the radiograph to be shown. Okay, on the image. See the oblique view. Macam ni tahu dia oblique view. Head of the metatarsal should appear directly side by side with no or minimum overlapping. Head of tarsal, metatarsal. Ni, tak ni overlapping tak pun tak ada overlap langsung juga. Okay. Then meaning ya oblique toes to be applied. Alright. Okay, so lateral toes pula. This is all the indication. Pathology, lateral toes. Okay, when you are projecting, for example, here the second toes. So lateral, you are yang lain tu you execute by just applying some macam ni macam ice cream kan, something that is radiolucent, takkan nampak ini. So you pakai yang jenis kayu ni, kayu takkan nampak dalam radiograph takkan secure the image quality of the radiograph, the anatomy itself. Right, so just apply like this lah. Sama juga dia katakan you are more on the medial side, the second, first, until third. Okay, you can apply the medial side lah. Actually much more stable use for the medial side compared to the lateral side juga. Okay, limit the beam. You can as well apply the tip to the patient. So the centering point is at the IP in the phalangeal joint for the first digit and proximal in the phalangeal joint for second to 5 digits. Okay, and directed vertical beam and perpendicular to the image receptor. And this is supposed to be appear on the image and projecting the lateral big toes here. Alright, you can see the interphalangeal joint here, the open space indicate through and lateral. And as well, optimal, it is the contrast ethnicity. They allow the visualization of the bony cortical margins and trabecular pattern as well as the soft tissue structure. In this case, the soft tissue is slightly soft. Okay, kita banyak mungkin high, a bit high KB for the setting of the exposure factors, but still acceptable. Alright, go for the AP. Straight away for AP, anterior posterior of the foot. This is all the indication. Okay. projected to be indicate the suggested image receptor is 1012. Either you split or not splitting, okay, depending on the anatomy, size, okay, length dia berapa banyak, besar mana kan patient punya kaki tu, and the exposure factor suggested is in between 50 to 55 and 24 to 3 ms. Happy foot, patient is lying atau biasanya duduk boleh, duduk lagi senang sit at the patient on the extra couch, knee flex. This knee is flex, easy for the position. Okay. Best plantar surface, contact with the IR, and support the side under examination with the knee of the other leg to immobilize the foot and leg. Kalau perlu, okay, any other. Kadang radiographer suka letak something lah depan ni, dia tak adalah bergerak. Kadang-kadang sebab licin tables tu kan. But then depends on macam mana you nak adjust. Okay. Present marker macam biasa, ankle limit the beam as well as apply the protection. Okay, tengok ada angulation kat sini. Due to the anatomy appearance. Dia kena angle a bit straight tube. Entering point to the third metatarsals. Okay. Then you keep posterior that towards the heel. The radiograph to be appeared. Okay, AP. How do you know through AP? The appearance of the joint itself. A bit soft here area due to the thickness of the anatomy, and the appearance can be seen some bones at the first big toe ni. Okay, indicates contrast and is just enough lah to visualize the soft tissue area as well as the bone vertical line and trapezoidal pattern. Right? Okay, oblique. Go for oblique. Foot. Alright, oblique foot. Kita nak tengok sama juga location of the fractures. Okay, AP and oblique. Biasanya apply for the basic projection. Kalau patient datang tengok tu. Okay, and then sit patient. The patient boleh lie down. The knee flex a bit. Okay. Place the affected foot on the cassette and raise the lateral border on the pad so that the dorsum of the foot is parallel on the cassette. Okay, you have to slightly oblique the foot until 30 to 45 degree, like that. It is to oblique. Okay, could be some support to the image receptor with the anatomy to be projected here. And it's the centering point is at the third metatarsal, using the vertical beam and perpendicular to the image receptor. Right, this is the appearance of the radiograph to be seen. Okay, how do you know it's and the AP oblique foot? There's no superposition, slightly or minimal superposition of the third to 5th metatarsals here. Alright, nampak clear the joint space here for the oblique. Okay, indicating good for the oblique. Sorry, good for the true oblique position. Okay. Ankle, so straight away to the anterior posterior of the ankle itself to demonstrate the bone lesions or disease that involve the ankle joint, distal tip fib, area of the distal tip fib or proximal of the talus, as well as proximal 5th metatarsal can be shown. Okay. So suggested if you are planning to split into two, you can use 10-12 or 8 times 10 inch of the cassette. Okay, exposure factor suggested is in between 55 to 60 and 3 to 5 ms. Right. Projection. Okay, patient. Okay, tengok betul-betul ankle joint with the ankle motif after this. This start dia memang banyak difference in terms of positioning. Yang lain semua lebih kurang sama except for the positioning itself. Ni dengan ini bisa motif. Okay. axis. So saya tulis guna mouse ni. Okay, mortis. Nanti tengok tulisan ni betul-betul tu. Okay. Mortis. So sit patient with the legs. Patient sit ataupun boleh lie supine on the extra couch. And the leg is extended and affected leg is abducted away from the region of interest. Place the affected ankle on the cassette with the joint flexed 90 degree. Allow patient to seated. Okay. Rotate the ankle immediately until the both malleoli. You have to feel the both malleoli here. Okay, the malleoli here, here and here. Should be equidistant with the image receptor is there. Okay. Membrane the lower leg, place the anatomical marker and clean the beam as well as apply the protection. Nampak dia boost ankle tu should be dia bukan digerakkan ni disebabkan you have to make sure both malleoli is equidistant lah with the image receptor. Centering point is between the two malleoli, midway between two malleolus, and directed using the vertical beam and perpendicular to the image evaluation on the radiograph showing distal. How do we know it is true AP ankle? You can demonstrate the distal part of the tibia fibula as well as the proximal part of the talus. This one is talus. Okay. Tibia and fibula. Okay, slightly superimpose. For AP ankle, kat sini slightly superimpose. Okay, superimpose at the end of the joint, dekat closer to the joint. Okay, tak mortis dia tak akan ataupun dia slightly je superimpose. Alright. Okay, go for lateral ankle. And lateral ankle. Okay, here is some new indication. Sprain is injury to a ligament that caused by tearing of the fibers of the ligament. Okay, sprain, joint effusion biasanya kalau mungkin sprain lah, motor sprain. If it is quite serious, maybe if this after apply this basic, we'll go for straight away to the MRI, for example. They need to be investigate more on that particular ankle. Okay, depends on the seriousness of the case. Yeah. So patient is lying ataupun seated. Okay, and with the affected side. Okay, close to the IR, like this one. Okay, rest and affected side in front or behind the affected side. Depending on the condition patient, depends on the comfort of the patient itself. Rotate the ankle laterally until the malleoli as superimpose. Okay, malleoli ni rasa dua-dua tu dia ada superimpose antara medial and lateral side tu. Mobilize the lower leg, place the anatomical marker, collimate, and apply the protection as well. Centering point is supposed to be at the medial malleolus. Okay, and directed vertical beam perpendicular to the image center. This is the radiograph to be seen. Right? And how do you know it is true lateral? You can see in profile of the calcaneum and profile of the talus as well as the cuboid. Okay, and the appear interjoint. The joint itself is open, indicates it is true lateral of projection of the ankle itself. Right? Other than the optimal density, dah bisa tengok kan? Then no motion, no rotation. How do you know though? Right? And then you can see the period of the fifth metatarsal navicular. Nampak ni, dia kata true lateral. Ni profile Okay, mortis joint. Biasanya mortis joint dengan tulis tadi nanti adalah lateral foot tu biasanya go for additional view. Tapi dalam belajar ni just go for that lah. for mortise joint, specific to the ankle tadi. You tengok, you tengok balik kat mana ankle tu. The basic one with the mortise joint. Apa difference dia? Okay. Kita akan pergi lagi sedikit yang detail nanti bila kita dah masuk untuk additional projection for the next time. So this is all the pathology demonstrated. Macam ankle pathology for the entire ankle mortise but this one is specific for the ankle mortise, area of the mortise and proximal fifth metatarsal. Boleh nampak fracture could be seen lah if ada dekat area of this. And then sama, okay, could be sama with the ankle AP basic, okay, but the only difference is the position. Patient is lying seated. Okay, this one is the key point. Keyword dia internally rotate entire leg and foot about 15 to 30 degree until the intermalleolar line is parallel to the receptor. Right? Place support and place untuk kaki macam ni. Bukan dekat je ankle but entire leg ni. This one is leg. Boleh rotate sana. Okay, about 40 degree. And as well as ankle. Okay. There's no angulation but the person, the patient need to angle immediately. Next section point is midway between malleolar lines, macam ankle and directed vertical beam using vertical beam and perpendicular to the receptor. This is the image to be evaluated or to be seen in the radiograph. Okay, somewhere distal part of the distal 1/3 of the tibia fibula and talus as possible half the metatarsal should be demonstrated. Kalau nampak sikit lah nampak metatarsal navicular ni alright, so kita nampak kalau ada area of the mortise ni sangat minimum. Only minimal superimposed at the distal tibia fibula. Distal tibia fibula. Kalau AP biasa, you akan nampak dia mostly superimposed. But for this one, nampak area of the mortise tu, so they go for minimum superimposed superposition. Alright. Alright. Okay, lateral foot sikit lagi. So pathology demonstrated. Pathology demonstrated could be kita more to the foreign body sebenarnya. Lateral foot especially. Location of the opaque. Remember what is the difference between the opaque and lucent here? Radio opaque and radiolucent. Lucent is the one yang tak nampak the radiograph. Whereby for the opaque can be seen. Radiograph. For examples. Okay. Kita discuss begitu. Okay. Ini tanda simbol apa? Fractures Alright, lateral foot equipment sama juga macam kita buat foot. Technical factors lebih kurang sama saja, except for the exposure factors you have to modify a bit because due to the ketebalan tu AP lain lah compared to the lateral side, a bit higher. And the lateral foot positioning, how do you position? Macam kita buat ankle juga, but you are focusing on this kind of anatomy lah. Instead of the ankle, you go for the foot itself. And the lateral side, patient in lateral recumbent, flex the knee 45 degree for balancing. Place the opposite leg behind the injured limb to prevent the over rotation. Biasanya patient the one yang unaffected tu, they just bend, but left behind je, right? Careful dorsiflex the foot if can be dorsiflex like this, straight, okay? For the aesthetic value to be applied to true lateral foot and ankle. Place the support under leg and knee, immobilize the patient, fix the marker, collimate the beam and apply the radiation protection for the patient. Centering point is a medial cuneiform at the level of base of third metatarsal. Okay, and directed vertical beam and also perpendicular to the image. So this is the image we see. How do you know it is true lateral? Of course, you can see the calcaneum is in profile. Alright, the talus, so as the cuboid. Okay. This is centering points third of base metatarsal. Sinilah kan, kita kata kat sinilah third of base metatarsal. Metatarsal kan, so third of base metatarsal tu, right? And then you can see a bit distal part of the tibia fibula is superimposed, indicates a true lateral of the foot. Okay, and as well as of the joint space tu, joint space. Can be appear open, right? Joint space tibio-talar joint is open. Okay, and itu macam biasa, no motion. How do you know no motion? Appear sharp of the bone itself. Optimal density and contrast to visualize the soft tissue as well as the bony vertical outline too. Alright, I think that's all. Thank you.